Pressure after that, you can elevate the extremity. The last ditch resort is to apply a tourniquet, and we only remove the tourniquet when the doctor gives us the okay to do so, because it can cause extensive tissue damage. The next one is talking about pathophysiology of hemorrhage and clinical manifestations. So essentially, guys, when you bleed out, your blood volume is reduced, so your blood pressure reduces, and your heart rate and your respirations go up, so your body activates the sympathetic nervous system. Please know the signs and symptoms of shock, which is hypotension, tachycardia, tachypnea. Just know that the fight or flight mechanism is activated, so cool, clammy skin, diaphoresis. Eventually, you can develop oliguria. You'll have pallor of the extremities. Oh, come in. Yeah, come here.
Everyone got their classroom?
No.
Yeah.
What time?
See you guys at 7 o'clock.
Okay.
7. Okay, thank you.
Bye, Mama.
Alright. Remember, guys, as the blood loss continues, the blood volume in the body will be decreased. Your perfusion to different parts of the body will also decrease, including your brain. How do you know the brain is not being perfused? LOC changes. How do you know your heart is not being perfused? You can develop angina. How do you know your kidneys are not being perfused? You develop oliguria, so on and so forth. Make sure you guys know it's at least 30 mLs per hour that are being produced of urine. Number 3, DNR orders, parameters, and legal duty. What this talks about, guys, let me see. Okay, if there is a code status that has been signed, then you have to oblige by whatever the code status is. If it's DNR, if it's been signed, I don't care what the family says, it's been signed, that's it with. That's it. If it's unclear what the code status is, we do full code regardless of anything. If it's unclear, if we don't have the actual documentation. Make sense, guys? And then, so, does that make sense? Yeah. Okay, cool. Stages of shock. So, let me see. Okay, so when your body's going into shock, your body loses fluids or whatever's causing vasodilation, but your blood pressure's dropping, right? Your body compensates. That compensatory stage is when your body activates the sympathetic nervous system that gives you the signs and symptoms that we just discussed. Does that make sense, folks? As the shock continues, one of the last things that happen is your oliguria, below 30 mLs per hour. As you're developing shock, folks, and it's getting worse, you should follow a trend of the output starts declining in its output. It doesn't necessarily mean it's going to be right away less than 30 mLs per hour, but you should see a significant decrease. So just understand, when it comes to the stages of shock, early on in shock, you're just losing volume, the output is decreasing, but you still maintain the 30 mLs per hour. Later in shock, it drops below 30 mLs per hour. Does that make sense, folks? All right. CPR parameters. If you have an adult who is unconscious and you've ascertained that there's no pulse and CPR is indicated, you call 911 first, and then you do a cycle of CPR. Make sense? And you start CAB, compressions, airway, then breathing. You guys follow? Mm-hmm. If it's a pediatric client, you do your cycle first, and then you can call 911. Make sense? Because you want to preserve the brain as much as possible. When you're doing CPR, the compression should be how deep? 2 inches deep. And you should see the chest go down and something called recoil. It's got to come back up. How do you assess during CPR that the cerebrum is being perfused? You can assess the carotid arteries, right? How do you assess the lower extremities are being perfused? You can assess the femoral. For lower, the femoral arteries. You guys follow? While you're compressing is what I'm trying to talk about. If you have a patient who is unresponsive, if they're unresponsive, you assess the carotid pulse. If they're responsive, you assess the radial pulse. If it's a pediatric client, you assess the brachial pulse. Does that make sense, folks? Mm-hmm. Okay. Treating hypothermia. Initially, you have to warm up the patient. We discussed frostbite a couple weeks ago. Just remember, when it comes to frostbite, you should not rub the fingers. You should not do anything to cause any trauma, because if you have frostbite, you may just break off the actual tissue. You can warm them up slowly. You can get some cloths or gauze preferably, and you can soak it in warm water, and you can wrap the hands with warm water to slowly decrease the frostbite. You guys follow?
Well, the other thing with that is, with frostbite, there's ice crystals in the skin.
Mm-hmm.
So when you're rubbing them, you're breaking all the cells, you're rupturing everything. You're doing a lot more damage than,
You guys ever put a Coke in the freezer and it's not, you thought you put it in there for just a little bit, and you take it out and you start drinking it and it's got the little ice crystals? Imagine those crystals on the finger, you start moving them around, it's gonna cut and break everything. So that's what Mr. Ortiz is talking about, yeah. When we do compressions for CPR, folks, we do it at what rate? 100 beats per minute, right? Okay. Nitroglycerin administration, folks. When somebody is receiving nitroglycerin, we give it to them because of some type of angina, regardless as to whether it's an MI or not. We give it for chest pain. You can give a max of 3 times. You give it once with chest pain. You position the patient laying flat or at least sitting down because the blood vessels will dilate, the blood pressure will drop. So you lay them flat or sit them down. You give it once, you wait 5 minutes, you give it another time, you wait 5 minutes, assuming they still have chest pain. You give it a third time, you wait 5 minutes. If the chest pain is gone, then that's great. If not, we treat it as an MI and we call 911. You guys follow? Continuing with the nitroglycerin administration and parameters, the nitroglycerin should be reordered every 3 months. It should be kept in a vial that's dark, in a cool place that's away from the sunlight, because the light breaks down the metabolites and then it loses its efficiency. Nitroglycerin, when it's given sublingually, it's going to cause a tingling sensation, and that's needed because that means the medication's still working. If the patient takes it sublingually and there's no tingling sensation, it probably needs to be reordered. You guys follow? People who are taking nitro patches, the medication is irritating to the skin, so you want to rotate the sites. You usually want to keep the patch on for 12 hours and off for 12 hours. You want to make sure that you use gloves when you're removing the patch to ensure that you don't have the effects of vasodilation. Make sense, folks? If you're if you're treating a patient with hyperthermia and you're cooling them down, you remove the cooling measurements as soon as they start shivering, because the temperature will continue to go down, and then you won't be able to, it's too late, but when you stop the cooling measures after they start shivering. Does that make sense, guys? And you want to give them a blanket also if they begin to shiver. So that's cold compresses. Treatment for epistaxis. Normally you want to pinch the nose, have the patient sit down and lean forward, and you can apply cold compress to vasoconstrict. You guys follow? Which brings me to the next topic, cold and warm compress. Cold is used to vasoconstrict, warm is used to vasodilate. Cold is used to reduce edema, warm is used to soothe muscles when they're overstretched, like in what's it called? Sprains and strains. Okay. Triage categories. So when it comes to the triage categories, what does green mean? It means that they're good, not priority, correct?
Yeah.
What about black?
Dead or.
They're not, it's,
severe.
unfortunately, it's not, you put that black tag on them, that's it, you're not gonna be treating them. That means that the injuries are too extensive for us to even waste time and resource. I know it sounds awful, but that's what you do in mass casualty incidences. What's happening in yellow?
They need,
Moderate.
Observation,
Moderate. What about red?
immediate.
Immediate treatment right now. Does that make sense, folks? So make sure you guys know those labels, review the book just to make sure. Anaphylaxis manifestations and treatment. Anaphylaxis is a systemic reaction of widespread histamine, so you have vasodilation. You're going into shock. Your blood pressure drops. Your airway starts constricting. What do you give to treat it? What position do you put the client on for any type of shock? Supine, with legs elevated. When would elevating the legs be contraindicated? ICP, okay, head or ICP, head or back injury or spinal cord injury. If the patient has a spinal cord injury or a head injury and we're putting them in the position of shock, we do not elevate the legs when they have those type of injuries. We just keep them flat. Does that make sense, folks? High risk burns and potential risk. So when it comes to burns, any burns to the thorax or the face, can signify smoke inhalation, which can contribute to carbon monoxide poisoning, which mimics hemoglobin, which will give you a false indication in the SpO2 monitor. It'll give you like a good reading. So if you suspect, if you have soot, what's soot?
Dust.
The black charred mucus, right? If you have the facial hair that's been singed off or any indications of smoke inhalation, you want to go ahead and do an ABG so we can look at the better oxygenation status. And these patients, as their airway begins to swell, they're going to sound hoarse, they're going to have stridor, coughing, they're going to expectorate soot, and at that point the patient may want to be intubated, so maintain the integrity of the airway. Excuse me, other high-risk burns or any burns to the hand or the genitalia. Caring for the asphyxiating client, you have to ask them if they're choking, or ask them if you can help them. They'll have the universal sign of choking. You have to ask them, sir, ma'am, are you choking? If they say yes, can I help you? If they say no, you let them pass out, and then you straddle them and do the abdominal thrust, right? If they are telling you that it's okay for you to help them, you get behind them, you put your thumb where? Between the xiphoid process and the navel. So right in between or right above the navel, and then you press in with a scooping upward motion, right, folks? If the patient is pregnant, where do you put the knuckle? On the chest, okay? All right, good. Head injuries and clinical manifestations to be considered. So anything that's indicating ICP is increasing. So level of consciousness changes, pupil issues, and of course the Cushing's triad, which is a widening pulse pressure, meaning the systolic and the diastolic will become apart. And remember, we're looking for trends, not so much individual values. So the systolic goes up, the diastolic continues to go down as time goes by, and you'll have bradycardia and bradypnea. Do not confuse Cushing's response with your signs and symptoms of shock, okay? Head injury is okay. If the patient has an open head injury, the biggest issue is bleeding and infection, of course. If they have a closed injury, the biggest issue is ICP. If the patient is suspected of having ICP or any surgery to the head, coughing is contraindicated. You should keep the head of the bed elevated. And remember, guys, right now I'm talking about ICP, not shock. So when they're in shock, yeah, you put them flat. But if they have ICP issues, you keep the head of the bed elevated. Carbon monoxide poisoning and clinical manifestations, we discussed that. The carbon monoxide mimics hemoglobin, so you need to get an ABG. When it comes to your clinical manifestations, the patient's gonna have like cyanosis in their mucous membranes, so cyanosis all over. LOC is gonna be changing. Remember, folks, that the clinical manifestations for carbon monoxide poisoning, usually whenever you have any toxicity or poisoning in the blood, folks, the oxygenation becomes impaired. So you have things like nausea, vomiting, headaches, maybe vertigo as well. Does that make sense, folks? So nausea, vomiting, headaches, vertigo. A pneumothorax is when you have a penetrating wound to the chest and air gets sucked into the chest after the lung collapses, and it pushes all the structures to the side. It's called tracheal deviation. You guys recall that? The treatment for an open chest wound is to cover it with an occlusive dressing, and you tape it on 3 sides to make sure air can facilitate outward, but nothing will go back inside. You expect absent breath sounds, or at least diminished depending on the degree of the lung collapse on the affected side, versus the unaffected side will have, hopefully, clear breath sounds. A hemothorax is the same concept, except a blood vessel ruptured inside, which changes the pressure and the lung collapses. The goal is to get rid of that fluid or that air that's being trapped in the chest wall. Atelectasis is usually happening after surgery. because of pulmonary stasis. That's why you educate the patient to cough and deep breathe and use the incentive spirometer. When we use the incentive spirometer, we take a deep breath and we hold it for 10 seconds, and we hopefully a little bulb goes all the way high, right guys? Okay. Okay, so diagnostic testing for the nervous system. We talked about an electrical encephalogram, right? We have to teach the patient that we should deprive them of sleep the night before, correct? When they put the electrodes on, there's not going to be any electricity that they're going to be feeling, but it's just going to be reading the electrical conduction of the brain. After the procedure, you have the patient wash their hair because they're going to use that gel substance on their hair. That's for EEG. For lumbar puncture, you have to, first of all, contraindications for lumbar puncture is ICP, right? Also, with the patient, you have to position them accordingly. That's what one of you guys said about positions. So this is the one that you have to position them accordingly. You have to make sure that the back is exposed and it's being bent over. The patient can be sitting up or laying flat in the fetal position with the back exposed to the practitioner. After it's also known as a knee to chest position, by the way. After the aspiration is done, you keep the patient flat. The adult client, you keep them flat because they can develop a headache. The pediatric client, because all of their structures are still immature, there's more flexibility when it comes to the pressure and the movement of fluids. So a child can get up and walk around after the lumbar puncture. You guys follow? You want to increase fluid intake because remember the brain gets very sensitive about losing the cerebrospinal fluid. How do I identify cerebrospinal fluid? Make sure that it's glucose, it's between 40 to 60. When you saturate the CSF into gauze, you'll have halos, yellowish tints. Normally, cerebrospinal fluid is clear, but when it's absorbed, it'll change the color because of the proteins inside. And yeah, okay. What other diagnostics do we have for the nervous system? An electromyogram, where they put these either electrodes or these little needles inside your muscles, and they're reading the electrical conduction. We can do that to rule out or to confirm multiple sclerosis, myasthenia gravis, amyotrophic lateral sclerosis. You guys follow? Okay. Any other diagnostic tests that I'm leaving out? CT, MRI, MRI, no metallic objects, CT scan, contrast medium, both of them assess for claustrophobia. What were you saying?
The healer.
Oh, that's a little inside joke. Medical preparation and urgent situation intervention. I don't know what that's about.
You have no idea how many times we see that.
Yeah, and I wrote this stuff.
We know.
Oh, I see what it is. Oh, okay. You guys don't know this, and I don't know what to tell you.
It was when we did the emergency medicine.
Yes,
Okay.
that's exactly what it's about. Yeah. Yeah. Okay. I'm not gonna go over that because otherwise it'd be like too obvious. RACE stands for rescue. It's for fires. You rescue, you hit the alarm, you confine, and then you extinguish or evacuate. Yeah. Therapeutic responses, guys, remember, never ask why. Always select the answer that allows the patient to verbalize their feelings more. If it sounds,
I was gonna say restate the.
restating is an appropriate therapeutic response if there's nothing else. ABCs is important for when you're assessing, folks. When you're assessing, right? When you're assessing, you always assess ABCs, airway, breathing, circulation. If you're doing CPR specifically, you do compressions first, open the airway, and you give the breaths. Does that make sense, folks? You follow? Stridor sounds like this. And it usually means that the airway is narrowing down. It can happen through anaphylaxis and a whole host of other issues like smoke inhalation. Average recommendation hours of sleep for ages 1 to 3, 3 to 5, and ages, I'll let you guys look those up. I don't know what they are, I forget. But generally speaking, folks, when it comes to like young adults, 17, 18, us, 8 hours. If you're younger, more hours. So let's say if you had an option between
It
like,
says 9 and 11.
to which age? Like adolescence?
Mhm.
Yes, 9, 11. If you're talking about an infant, how many hours? Like 22, 23 a day, okay? And what happens as we get older? Yeah, we still get the 8 hours, but all throughout the day, scattered throughout the day. So that's why we take little naps throughout the day. I wanted to take a nap a little while ago, but the boss was in here, so I did not. Let me see. Kubler-Ross's stages of death and dying. The first one is denial. No, it's not happening. The second one is the second one. Anger. You're pissed off. You're cursing everyone. The third one is not yet. Oh wait, hold on. Bargaining. Yes. Then is that what you said?
Yeah.
Sorry. Then it's depression, and then it's acceptance. Yeah. Sorry about that, Miss Susan. Alright. Assessment before, that's a concept. Whenever you're dealing with patients, folks, you always want to assess before you intervene or before you snitch and report. You always want to assess first.
Snitch and report.
Yeah. Clinical manifestations for depression. Patient usually is unkempt. They don't comb their hair. They don't dress too well. They're always bumming it. Okay. The patient tends to stay in bed and be antisocial for a while, and they may develop suicidal ideation. You always want to ask the patient if they become suicidal, because they'll be able to tell you yes. Okay. And or you ask them, do you have a plan? Do you have a blueprint? They'll tell you yes. Anti-seizure drugs. We talked about a lot of them, folks. Let me see what they have in here. Just know what I was discussing. When it comes to your, all anti-seizure drugs do what? Suppress the CNS. And I've seen the test, folks. In reality, that's the extent of what you have to know about the side effects. But remember, the barbiturates, your phenobarbitals, they have barbaric side effects that they also do myelosuppression. Even though when I was looking at you guys' book, it didn't show it there. Your dilantin or your phenytoin, it's the same thing. Gingival hypertrophy, you provide a lot of oral care for these clients. You do not want to give another CNS depressant with any anti-seizure drug, because it's going to have a synergistic effect and may drop the respirations. The patient may stop breathing and die. SBAR is for what?
Situation, background,
What's it for
assessment,
though? What's it for?
Assessment?
So we do a plan of care, right? Care plan, right? The SBAR: situation, background, assessment, and there you go. The Snellen test. The Snellen test is a chart. I think Miss forget
Go ahead.
Miss Irma, you had it, right? The little form. It's the one that has like the backwards E and all the other ones.
The eye exam.
So it's called the Snellen test. You have to stand 20 feet away from the
Miss
the
Monroe's
chart.
making copies for our clinical.
Yes. You have to stay 20 feet away from that. And please make sure you guys know that the first cranial nerve is what? The
Olfactory.
So you don't need a Snellen test for the olfactory, right? Good. What about the second cranial nerve? What's that for? Optic. Optic deals with what?
Vision.
Okay, and what about the third one?
Olfactory.
So which of those three will be used for the Snellen test? The second one. Which one of those would be used for when you get the pen and you move? Oculomotor.
Three.
Which one would be assessed to see if you could smell?
One.
Okay,
Olfactory.
we're good. The parasympathetic nervous system decreases your heart rate and activates your digestive system and salivation. It's parasympathetic, right?
Yeah.
And then your sympathetic nervous system activates your fight or flight. It increases heart rate. It increases the constriction of your peripheral blood vessels because it gets you ready for fighting. And it reduces your gastrointestinal function. Make sure you guys know when one is activated. Like if I say the sympathetic is activated, it's easy to remember the vital signs that they all go up, right? But it's the GI systems that they slow down their function, because that's not what the body's working on at that particular point. Animal insect bites. The one that we really talk about are the bee stings. You gotta get like a sharp something, like a credit card or a knife, and you flick it off the actual skin. You don't want to pinch it with tweezers or anything like that, because you're gonna inject more of the venom. If the patient starts developing a widespread rash and their airway starts constricting, what do you want to give them?
Benadryl.
epinephrine. You never give epinephrine to the digits because it's gonna obstruct the flow, because epinephrine is a powerful vasoconstrictor. And you're gonna cause, you guys recall Buerger's and Raynaud's disease? It's gonna cause that type of symptom. It's gonna constrict all the blood vessels and you may damage the fingers permanently.
I had one instructor that said, epinephrine never goes into the, nose, ears, fingers, toes, or the thing.
Oh. I'm on the thing, what the?
You ever wanna put epinephrine on that, for that reason, because it's a vasoconstriction. So we're, nose, ears, fingers, toes, and the thing.
Let's see. We're almost done, folks. Not really. Whenever you have a patient that has some type of fracture, the first thing you do is what's in the extremity?
Mobilize.
Immobilize or splint it, yeah. Okay. There's a question about lightning and how do you prevent it. I'll let you guys figure that one out. If you guys don't know it, then yeah, you have a problem. Primary and secondary prevention. Normally when it comes to these type of preventions, folks, primary is to prevent the actual disease from occurring, so like a vaccine would be appropriate for that. Does that make sense?
Yeah.
Secondary prevention focuses more on the already active issue and minimize its potential complications. Does that make sense?
What does screening go into?
Say that one more time.
Screening like mammograms and
Primary, because all of that stuff is gonna be to prevent. Yes, sir.
Secondary would be like antibiotics.
Yes, because of the current infection, yeah. We wanna prevent that infection from getting worse. And then tertiary interventions would be when the patient has had an issue, let's say syphilis. Do they have a syphilis vaccine? No, right? Okay, so let's pretend they had a syphilis vaccine. Guys, we're just pretending for the sake of the illustration right here to prove my point. If we had a vaccine for syphilis, to prevent it, primary intervention would be to give the vaccine so the patient does not develop it. Does that make sense? Secondary intervention would be to treat the infection, so they give the antibiotics so it doesn't get too bad. If the syphilis, if it's spread and it caused neurologic damage, because that's what syphilis eventually attacks your nerves, then tertiary intervention would be to rehab, to maximize the recuperation of the patient. Does that make sense? Mosquito bite prevention and education. Do not go out during dusk hours at like 6 p.m. and all that. Make sure you remove any sitting water around the house. Make sure you wear long sleeve clothing and turtlenecks. Make sure you wear mosquito repellent. You guys follow? Yes. Okay. The rule of nines. It says that you can divide the whole body into segments of nines. Let me see, what's the question?
It's
It
page one.
shows you an illustration, so make sure you guys know. The torso, the
18.
anterior torso is 18, the posterior torso is 18, the upper extremities, my entire right arm is 9, my entire left arm is 9, my entire right leg is 18, my entire left leg is 18, the perineal area is 1%, and my cephalic region is 9. For the child, the kid, the head is 18 because they have a huge head. You guys follow? Okay, we'll discuss that more in module 10 or 11, I forget. Let's see, burn stages. So we talk about superficial, it only affects the epidermis. Your partial thickness includes the epi and dermal layer. Your full thickness includes all structures down to the hypodermis, thank you, and beyond. If the question says something about shallow, that just focus on if it's partial thickness or what the label is, because if I say the patient has a shallow partial thickness burn, what part of the skin is it affecting? The epidermis and the dermis, because I'm saying partial thickness, but when I say shallow, it just means that it's closer to the epidermis. If I say the patient has a deep partial thickness burn, it's still the epidermis down to the dermis, excuse me, but it's closer to the subcutaneous tissue. Does that make sense, folks? Okay. Remember that your first degree or your superficial burns will be painful, but the skin is still intact. Once you have blisters or any weeping of the skin caused by burns, that's a partial thickness or second degree. It's very painful, as is the first degree or the superficial. Once you get to the third degree burns or the full thickness, you've severed and damaged all the nerves and you've burned them off. So the pain is described as dull pain. Remember, whenever you have a 20% body surface area or more, that's at least partial thickness, that's when you have to worry about hypovolemic shock, hyperkalemia, disseminated intravascular coagulation. We did intake before, right? No?
No, we don't use
Okay, well, it's the same concept. We talked about smoke inhalation, different types of parenteral fluids. So look, when it comes to regular patients that just to give them regular fluids, normal saline. Any patient that's experiencing an urgent situation, Ringer's lactate, because it's got a bunch of plasma expanders and electrolytes. You guys follow? Define laceration. Laceration is a jaggedy cut into the skin. It's linear, but it's like, if you go get a cut at the surgery center, it's called an incision. If you do some backyard surgery on your back, then it's called a laceration. You guys follow? You get cut by someone, it's a laceration. A contusion is a soft tissue injury. It will cause, edema, swelling, all that stuff, ecchymosis. An abrasion, the skin is cut. You have scrapes. And a puncture is being poked. I had a dream last night that I got stabbed, like a poke puncture. It was really scary. You guys ever had dreams like that? No? Good. Infection prevention, folks, wash your hands. That's the best way to do it. Seizure precautions includes getting the patient's room ready, having artificial airway or suction equipment at the bedside, emergency IV medication. Even though we don't administer the IV medication, it should be at the bedside just in case if the patient goes into status epilepticus. You gotta pad the side rails, pat the headboard of the bed. You have to leave the bed at its lowest position when you leave the patient's room. You have to decrease environmental stimuli. You guys follow? Okay.
41.
Thank you. Aquathermia pads. I forget what that is. I told you guys earlier. What was it?
A cooling pad to help with swelling.
I'm tired.
So look, aquathermia pads, folks, water. So mind you, these are like cooling blankets, folks. But the difference is that it could be cold or hot. So the issue is for people that have sensory issues. You gotta be careful with the extremes of temperature. If it's aquathermia that's at the warm setting, you have to look out for the indications of like your superficial and partial thickness burns because you may burn them. And if it's too cold, you have to assess for maybe pallor and indications that there's reduced blood supply to that particular area. You guys follow? Yeah, Capri-Fuel is good for that too. Does that make sense, folks?
Yes.
Okay. What's the manifestation of a superficial burn? What color will the skin be?
Red.
Reddish. Yeah, erythema. Okay, good. We talked about seizure precautions, indications of head trauma, altered LOC, when your pupils are not how they're supposed to be, when you have altered vital signs, again, widened pulse pressure, bradycardia, bradypnea. Number 44, caring for the unconscious client. When you're caring for the unconscious client, you have to talk like if they can hear you. If you're gonna provide oral care, you have to do it when they're laying on their sideline position to facilitate the evacuation of any fluid so they will not aspirate. Again, sideline position, folks. And talk to them like if they can hear you. Let them know exactly what you're gonna do. Assessing the cranial nerves. So if I tell you guys, I think we discussed that, right? If you're doing the Snellen test, that's the optic nerve. If you're doing the, if you're trying to see if you can smell, the olfactory. If you're trying to see if the patient can chew well, that's the trigeminal nerve. Bless you. If you're trying to see if the patient can move his or her face or wrinkle his or her forehead, that's the facial nerve. If you're trying to see if the patient can shrug his or her shoulders, that's the spinal accessory. I had forgotten about it. Yeah, but the spinal accessory one. If you're trying to see if the patient can have proper balance, that's the acoustic or the vestibulocochlear. Same thing with hearing. Review all of them, guys. Okay? Strabismus and nystagmus. So strabismus is the biggie syndrome where your eyes get cross-eyed. That's strabismus. That usually indicates, I forgot to talk about this. A lot of these seizure medications, strabismus and nystagmus, which is the bulging of the eyes, not the bulging, excuse me, the bouncing of the eyes, those are indications that the CNS is too depressed, and that's where the eye coordination is not effective. So any strabismus or nystagmus, again, strabismus is cockeyed, nystagmus is the bouncing of the eyes. I'm sorry, you guys, anyone have strabismus here? I'm sorry.
I need one.
That's just how it is. I'm sorry. Okay. Oh, by the way, strabismus and nystagmus in the pediatric client, if it's a neonate, it's expected because their nerves are not fully developed yet. And you guys ever held a newborn and they kind of just look at you and you're thinking, oh my God, he or she can recognize me? Nah, they're trying to find out what blob is in front of them because they can't see that well. So because of that, nystagmus and strabismus is common in the pediatric client, in neonates in particular. A child is ready to have an eye exam at the age of 6, according to the book, because at the age of 6, their nerves and muscles are coordinated enough to be able to partake in the Snellen test. I don't think that's a question, but we'll discuss that in chapter 31 later on. ICP for pediatric clients. Everything's the same. The difference is for the baby, you can tell because of the fontanelles, the soft spots, they're still open, so you'll have a bulging fontanelle. You guys follow? Bulging fontanelle? No? You guys look at me like I'm crazy.
Yes.
Yes.
Okay.
Well,
Assessing LOC. I think we know how to do that, right? You ask the patient if they're alert and oriented. Glasgow Coma Scale. I think we talked about that before also. Remember 4, it's right there. 5 is the max here. 6 is the max down there. 15 points is the max. You want above 8. Anything less than 8 indicates some degree of comatose. A 3 is full comatose. That's the lowest score you can get. Bell's palsy. People with Bell's palsy is what cranial nerve?
Facial.
The facial, so the herpes, yeah. It's the 7th cranial nerve. The patient will have unilateral paralysis of the face. Their tongue, they can't taste that well. It feels like they burn their tongue with like coffee or something. Everything tastes raw. Their eyes cannot close. So because of that, when they sleep, you have to tape the eye shut, which is what I did, or you have to wear an eye patch because you may scratch the cornea. Or imagine you're laying in bed, this eye's closed, and you're rolling in bed and your eyes open and you're scratching the cornea. You guys follow? Okay. Promoting sleep and rest, believe it or not, warm milk, okay, helps them out. Decreasing environmental stimuli, make sure the room temperature is at about 70 something, I think 72, 74, I don't remember what the book says, read it. Decrease environmental stimuli, make sure the patient does not exercise right before sleep. If they exercise throughout the day, that's appropriate because then they'll be tired, but not right before sleep. Make sure that they void before they go to sleep so they don't have a full bladder, things like that. Mental status examination for the, I threw that question out, I'm sorry. CSF leakage indications, we discussed that already, right? What can cause CSF leakage?
Trauma.
Head trauma. Clinical indications of CVA, hemiparesis, hemiplegia, hemianopsia. If it's left-sided stroke, depression, right-sided stroke, belligerent